Well, nice to see you all. Many of you I know. I've been in the area for many years, since the early 80s. So been in the practice in Lafarge, working for over 30 years now. So as many of you know, I'm kind of a jack of all trades, so I work with people of all ages and all conditions, not just the Amish, the English, and everyone in between. So this particular project has just been something that's developed over the last 3 to 5 years and has increasingly drawn my excitement and passion along with the other work that I do. So I'll say a few words about the practice and the project. So what we're looking at is developing a set of practice conditions for children with rare genetic syndromes. I've been seeing these children in the homes for many years in the Amish and Mennonite communities, but didn't really have much of an opportunity to clarify what was going on there. I've heard about folks out on the East Coast who have been doing this work for quite a lot of years, and I've had the opportunity to get acquainted with them and to develop a practice that emulates some of that work. So I can see my slides better here. So we've been there since '83, and for those of you that know the area, coming to a place like Lafarge back over 30 years ago was in some ways a leap of faith. There wasn't a lot happening. I did look at some links at the maps and all the little burgs and townships and population, and looked at that time as where healthcare resources were. And at that time, to the south, the nearest healthcare was Richland Center, and then to the southwest in Soldiers Grove, of course to the west here Hillsboro, to the north it was Sparta, and to the east Hillsboro. Now since then there have been some other spots in the map, Scenic Bluffs and Cashton, with a lot of good work. My sense was at that time that this was centrally located in a large underserved area that, if it was set up correctly, could end up building into quite a significant practice. And I think those initial impressions turned out to be true, because as time went on, things have gotten busier and busier. Our first partner was added after 5 years in solo practice in 1988. After about a decade in practice, we were running out of space, so we actually put a floor on the stairwell going into the basement, and had a space where we had 3 people working in about a 6-foot wide narrow hallway with no windows. That went on for several years until our clinic expansion in '92, which basically doubled the size of our clinic. At that time, I was rattling around in this space and thought, we'll never ever use all of this room that we have. Well, within about a year after that, I began to respond to the issues in the Amish and Mennonite communities related to obstetrics. That was one of the first areas that I branched out into. Of course, I worked as well as that work. I worked for 20 years here in the emergency room in Viroqua at the ER, plus of course hospital patients, and received in the ER many Amish patients coming in the night with postpartum hemorrhage and other complications of their deliveries. And it was very evident to me in that work that there really was help needed in that plain community for birthing related complications. So actually about 20 years ago now, over 20 years ago, we began doing that in the clinic. Originally I planned to try to do it here at the hospital. I couldn't quite seem to get it worked out, and one day someone came in for their prenatal visit and had a few contractions on the way, and it was her 8th or 9th baby, and it's easy to visualize when I checked her she was about complete, and we just went ahead and delivered her. And I thought, well, why don't we just do it here? And that's what we began doing. Now, since that time, we've done over 1,500 births there at the little clinic in Lafarge. In 2004, about a decade ago, we added our third full-time doc, and now we're actually recruiting for our fifth full-time provider, and we've grown out of this space in the last 5 years or so. So we've been struggling to see the patients that we need to, don't have any room to put anyone as they're all coming in the door, plus having people in labor in the back room. So we are in the plans and just about ready to move into our new clinic. I didn't know much about the Plain community when I first came to Lafarge, so I'd had no training in that area, didn't really know much about it. The Amish moved about 20 years earlier than that into the Cashton community. There were a few of the original families and the elders, most of whom are gone now. One of the last ones just passed away this last week, Kid Miller, who I've known for many, many years. And most of those original elders in the community are now gone. There's one other left, I think, and the rest have passed away. So those are in our age now that are going into the next era. But why exactly we became engaged with the Plain community isn't really clear to me. What I do know is that for many years I worked with a lot of people without much resources or finances in that area of the Kickapoo Valley. So I worked with a lot of uninsured people. Perhaps all of that work made it natural that I'd work with some with the Amish community. So just one way or another, we gradually gained trust with the community, and increasingly they began coming in. I got more and more acquainted, and of course the birthing services we began over 20 years ago has just really been for the Plain community. It was designed really to meet a need of underserved in the obstetrical community. So most of our English patients have good access to Badger care if they're pregnant, and so they can get good care here through the hospital in our work. So that's focused there. Currently, it's less than really 1 in 5 of our patients at the clinic are from the Plain community. My practice, maybe 1 in 4, but in that range. So still, most of the work we do is with our regular community, our English community. So over these 20 years of birthing at the clinic, we do about 80 to 100 births a year. Increasingly complex births in the early years. Of course, I was trained in the modern era in OB and what I call hand-wringing obstetrics, where we mostly just worry. We worry through the labor and we worry through the delivery, and that's the way I was trained, and that's what I did. And so it wasn't easy for me adjusting to the view of the Plain community. So for the first year or two, I tried really hard to get these patients who'd had prior C-sections to come to the hospital. This was supposed to be a practice for low-risk patients. But I would negotiate and negotiate with them, and many times they would end up saying something like, well, we understand, doctor, if you're uncomfortable with us having the baby here, we can have our baby at home, and we'll just let you know if we have problems. And so that was kind of the response I had. So I thought, well, does that make sense? Or does it make sense to do it in the clinic where I've got an ambulance across the street, we've got trained nursing staff, access to IV fluids and medications and whatever we need there. And so gradually I began to accommodate, and we did things like twin deliveries and breech deliveries and such like that, and things that I never would have anticipated doing. So as in many things in life, I've learned as much from the Plain community in terms of birthing as I've offered to them, and gained a lot of experience in these matters. And it was rather frightening to me 5 or 10 years ago when Dr. Starr finally retired, and people looked to me for the experienced person in OB. Of course, we have Dr. Pryor now. She's taken in that role as well, but it's rather humbling and intimidating, really, because we've really had some very skilled elderly gentlemen who knew what they were doing in OB. And so I've learned as I've gone along, and gained a lot of experience in some of these complex issues. With our Amish practice, there's not a lot of routine care coming in the doors for like yearly checkups or well child exams. About a quarter of the work we do with the Amish is related to birthing. A bit is trauma and other illness. This is a map that reviews some of the Amish communities. I don't know if that's a pointer. Oh, it is. So here we are here, and there's, of course, we've got quite a few Amish communities here, but as you see to the north, there's really a large population, much like our own to the north of us, so we've been working with this population as well. We have not really reached out as much yet to the Kingston community, and there are lots of Amish communities and families out in that area, and we're hoping with some of our work, and then to the southwest, quite a bit as well. We also have meetings with the Plain community and healthcare providers on a quarterly basis, kind of problem solving, looking at issues in the community, things we could do better as a medical community. And so we're going to start moving these out to some other areas. Most of them we've had around what's convenient for us, which is in our area. We've had one or two now up around, Augusta in this area. I think one of our next ones will be over in Kingston or maybe in the southwest. So we'll engage more of that community and learn what their issues and troubles are as well. There's probably around 20,000 Amish in the state as best we can tell. The Mennonite community isn't quite as large. It's probably a third as many, and they're also dotted throughout the state. As many of you know, if you've worked with some of these communities, the Mennonites are not quite as conservative. They often drive. They have electricity. Some of them have computers. And it's variable. Much like the Amish, each church district has their own kind of rules and regulations. Same thing is true in the Mennonite community. Interestingly, the genetic disorders in the Mennonite community are distinct from those from the Amish community for the most part. There are a few disorders that are seen in both, but most of them are distinct. These are some of the conditions we've seen in Wisconsin. The actual list of identified genetic syndromes in the Plain community is about 200 disorders. So we're adding on to this as gradually over time. As we go down some of them, for example, cystic fibrosis, relatively common in the English community, is not really seen in the Pennsylvania Amish. So there are certain groups of Amish that don't seem to have those genes and don't get those disorders. But we've got cystic fibrosis in our Amish community here. Hemophilia B is quite common here, factor IX deficiency in the Amish community. So we see a lot of hemophilia. Interestingly, most of that is cared for through Scenic Bluffs Health Center in Cashton. They've really developed a nice plan with Gunderson Lutheran in providing factor, and they have a yearly clinic with the Plain community, and it's almost all factor IX. In the English, it's much more hemophilia type A. Hypertrophic cardiomyopathy is a condition I've been spending quite a bit of time working on. This is the most common genetic disorder, well, throughout the U.S., actually, in the English and the Amish. So I think we had a young man in Viroqua who passed away a few years ago during a hockey game, a 15-year-old or so. That was from hypertrophic cardiomyopathy. So this is an area, this is a genetic disorder. It's dominant, which means half of the siblings have it, half of the children of a person with the condition have it. And in the English, so outside the Plain community, the genes that cause this, there's about 10 or maybe 12 genes that cause this condition. Up until the present, doing a panel to figure out what the cause of it is in an individual patient is still kind of pricey. So if you were to send a panel for hypertrophic cardiomyopathy to the West Coast or Mayo, it might be, I don't know, $5,000 or $10,000 or something. But really it's the way to go, because it's very easy then to screen family members, who has it, who doesn't. Much more economical than doing echocardiography, which isn't as helpful. In the Amish, there's one mutation that causes it. So once you identify someone who has the condition, you can simply do the gene test to confirm it, and then you can do the testing on children and siblings at a very low cost and know immediately which in the family have this condition. The next condition, lethal neonatal rigidity, is children who are born with spasticity and seizures right from birth. And we have a family, I'm pretty sure, that has it. I haven't had their acceptance to do the gene testing yet. They've moved to the southern part of the state. We've got a family in the Wilton community with long QT. This little baby had a heart arrhythmia, had to be shocked a few times at the ICU up at Lutheran, and had a kind of a hard time. Maple syrup urine disease is seen just in the Mennonite community, not in the Amish. That's just a few. I could go on, but this severe combined immune deficiency, maybe I'll mention, is another RAG1. Very rare in the English, maybe 1 in a million or so. But the gene frequency for this up in the Tomah-Wilton community is probably 1 in 10. So that we've had, I think, 7 children die with severe immune deficiency from the Wilton-Kendall community. This is the kind of condition in which the child has no immune system, like the movie that had the child lived in a bubble or for a while. That's this SCID, or severe combined immune deficiency. So it's very common in our community to the north and east of us. We've got families in our practice with SNP1, with Troyer syndrome, and with Yoder dystonia, other conditions. So I'm going to give a few examples, and then hopefully we'll finish up with, plenty of time. Well, we're doing well with time. So I'm going to come back for just a moment to the issue of hypertrophic cardiomyopathy, the condition that can cause, it's the most common cause of sudden death in athletes, young athletes. So we fret and worry about it, but fortunately for all the young people who have this condition, it's very rare that anybody collapses and dies. So it's a rather difficult thing to know how to manage in the general population. But in my practice, I had a gentleman who came in about 40 years old with shortness of breath, had an obvious heart murmur. We did an echocardiogram, which isn't so easy to do in the Amish because they cost $2,000 to $3,000, and of course they pay all of that. But they accept it sometimes. In this case, the guy couldn't breathe, and he had a loud heart murmur, and we did it. And he had hypertrophic cardiomyopathy. I sent him to Mayo Rochester, where this muscle gets so thick it obstructs outflow of blood from the heart. So it's literally that thick. So they actually just cut the muscle and remove that portion, and the blood flows by, and usually the symptoms are much better. He's done well. This has been about 8 or 9 years ago. So he lives a full life and does a lot of activity. At that time, their advice to this gentleman was, when you go home, you should advise all of your brothers and sisters to have an echocardiogram, because half of them are going to have this condition. And then of his children, since it's a dominant condition, 50% of the children will have the condition as well. Well, as you know, in the Amish community, there's a lot of siblings and there's a lot of kids, so this is not exactly easy. So he actually has 14 sibs, so there's 15 kids in his family. An echocardiogram at that time probably cost about $2,000. Now it's about probably $3,000. So just doing the echoes on his sibs is about $45,000. And then he's got 10 kids, so you've got another $30,000 or so there. So you're looking at $50,000 to $75,000 just to do a baseline echo on the first degree relatives of this particular patient. Well, you know, if you talk to an asymptomatic Amish person and say, I think you ought to have this echocardiogram for $3,000, they look at you like are you kidding, you know? They're going to write a check for $300 a month for the next year just to make me feel better, or, you know, that they're okay, they don't have some condition. And so, as you might expect, that really wasn't done. The other problem with that is, since the expression of this condition is variable in age of onset, so you might do an echocardiogram in a 20-year-old, it might look perfectly normal. 25, maybe normal. 30, it looks a little unusual. 35, a little more unusual. By age 40, maybe it's... So really, you're not free of worry even if you have a normal echocardiogram. So literally, in the family members of somebody with hypertrophic cardiomyopathy, periodically, either if they get symptoms or every 5 years, they get an echocardiogram. So this was the past. And this is the present, with a particular gene in the Amish community, this MYBPC3 gene mutation. I can do this through the Center for Special Children in Pennsylvania, or the DDC clinic in Northeast Ohio for $75. We can gene test them for this specific mutation, and we can tell all of this gentleman's siblings they either carry it or they don't. And they don't have to do this, well, it looks okay now, but we don't know, maybe in 5 years that we'll see these changes. We know one way or the other, do they have the condition? If they don't have it, that's the best scenario. Let's say that this gentleman, half of his siblings did not carry the gene. So none of their children have to worry about the condition either. And of course they have many children too, generally, 6, 8, 10 children. And so it really, they can breathe a sigh of relief and not have to really fret or worry about that. If they are positive, then they need to have an awareness of this issue, and we discuss it and what we need to do, and basically figure out how to evaluate the problem in an economical way, which we can do. So it's really changed the face of the treatment of this condition from as recently as 2006, coming from Mayo Rochester, to 2015, where you can do this sort of gene testing at such a low cost and give such much more satisfactory information to the family. Now, much of this wouldn't have been possible without the work of the Human Genome Project, which began, let's say around the year 2000, I don't know. They worked on it for about a decade anyway, spent billions of dollars across the world, focused on that issue. And what they didn't realize is that a lot of the trick of this gene sequencing wasn't going to be solved in the scientific laboratory. It was actually solved in the IT department. All of our computer geek colleagues, like my kids and others, they're the ones that figured out how to do this gene sequencing of huge numbers of genes and figure out how to do it inexpensively. So the progress with the Human Genome Project went slowly, 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 and then it just accelerated. And in the last few years, they sequenced the genome in no time and ended up ahead of their schedule. Now you can do the whole genome sequencing for, I don't know, $5,000 or something like that. And the trick now is interpretation of all this data. So you get literally reams of these numbers, as some of you remember from your DNA twisting and sequencing, A and T and C and G and all of this, hundreds of thousands and millions of digits, and then you have to make some sense of it all. So actually it's coming back to IT. It's these people who can do this large data analysis that are sorting out what does it actually mean with these variations in these genomes. But as a consequence of this rapid gene sequencing and the advances in this genomic medicine, these kinds of tests have become available, at least in some select places, at a low cost. Now, I wouldn't mean to say that you could draw blood if you had a relative or a sibling with hypertrophic cardiomyopathy and we can get it done for you for $100, but you should be able to, and you will be able to in the next 5 years if we can make some places where they're not looking to make a lot of money. So if you send it to Mayo, it's going to be $3,000 for this test, and the same thing if you send it to the West Coast, some of these Genomatic and all these places that they're doing this testing. But there are a few select places, they're not there really to make money, they're really there to serve the community, and we have direct relationship with these people. We're acquainted. I'm going next week to a meeting in Ohio with the DDC group, and the gentleman from the CSC, Dr. Holmes Morton, who's really the world leader in this work, was here last Monday in Lafarge. We spent a day working with the Amish community there, and so we've developed all these connections with these experts in the field. So some of us are beginners in the area. We're just kind of helping to learn and sort through the issue and guide people, but we're getting further help along the way. Another condition I'd like to compare and contrast with the past and the future is propionic acidemia. This again is a rare syndrome in the non-Amish community. Maybe 1 in a million or 1 in 500,000, so we don't see it much. If we did see it, we wouldn't know what we're looking at. And these children get sick often early in infancy. they may die without a clear diagnosis. This particular child was delivered about a decade ago, maybe 9 years ago. She's 9 now. She had a catastrophic neonatal course, kind of a blue baby, delivered at home by the midwife, wasn't doing well, brought her to Viroqua, transferred her to Lutheran. They worked with her a while. They transferred her to Mayo. That little baby was in the unit there for a month on a respirator and trying to get help. They really weren't sure quite what was wrong. They tried everything. At the end of it, they thought, well, they didn't really have much left to offer. It didn't really look like this child was going to survive, so they transferred into kind of a palliative care, comfort care mode, and sent the child home. Well, she didn't die. She got good care from her parents, and with a little luck and nurturing and bottle feeding and such, she did survive, and actually then she grew to thrive a bit, and she doesn't have cerebral palsy or anything that you would expect commonly would be a consequence of such a devastating illness. She's got a little slow learner, but she's a bright little girl in her own way. So she was seen at one of our clinics this summer with the UW Weissman Center team that was working with us there in Lafarge, and they did some initial testing. It turns out she has propionic acidemia. This was tested for at Mayo, but it wasn't found. The testing, of course, has advanced in the time since then. They never really did make the diagnosis. I sent a letter to the neonatologist who cared for the child at Mayo. First I checked to see if he was still there. He was, and said, I was sure he would be interested to know all this hard work they did, but they didn't find the answer. Well, this was the answer, but I didn't actually get a call back from him. I'm kind of surprised that but maybe it got buried in the email stream or something, or the. But so this was the situation back a decade ago. You could imagine that this cost in a neonatal intensive care unit probably would be nearing $1 million, $750,000, something like that. So here's the present. We just had this same family actually who was ready to have another baby, and they delivered in the clinic in December. So they had a 1 in 4 chance. This is what we call an autosomal recessive condition, meaning 1 in 4 of the children statistically will have this condition. They have 7 children prior to their current baby, 1 of them affected, and of course they didn't know what it was until just this summer. But in December she had her baby. She had a special formula to use since we knew the condition of the sibling until we got the testing back. And within 48 hours we had a gene test back from UW in Madison, and this little baby that we delivered in December has propionic acidemia. Of course, since we knew the condition in the sibling, it's fairly straightforward. We just draw cord blood and send it to Madison, and within short order we've got an answer. So this child then was given proper early treatment and a special formula right from the outset, and she's 4 months old and doing fine, and hopefully will live a full and rich life. Now when I spoke to Dr. Morton last week about it, he said, 2 days it took you. That's kind of pokey. We could do it at our place in 2 hours. So I thought, well, okay, but still it's pretty good, and it's getting better all the time. So it's changing the face of the community in that children with various disorders are now being identified, not all of them, but many of them, most of them, over time, so that we know what's in the community, we know what's in a family. If we already know they have a condition in the family, well, it's relatively straightforward with this new gene testing that we can do to test the new baby that's born. Here's my last example of the difference this has made. This is a condition called Yoder dystonia. It's a condition causing developmental delay in infancy. These children decline in spite of the best efforts. They don't develop normally. They develop a kidney affliction called nephrotic syndrome, where they spill a lot of protein in the urine and they become edematous, swollen. And a child like this, you could imagine if they were at UW or at Mayo or at Gunderson Lutheran, not doing well, not developing well, the amount of testing that could be done trying to understand what's going on with that child. And of course the parents would be yearning for that as well. You know, please give us an answer. Is there something we can do to alter the course of this? Some change in their diet or a supplement or medication to help. But they could look and look and look, spend tens, hundreds of thousands of dollars and not find an answer to this condition, because at the time this was described, there still wasn't even anything in the medical literature published about this. So they're not going to be able to look it up and figure it out and do just the right tests. So they would do hundreds of thousands of dollars of tests, put a little infant through, let's say, an MRI machine, which if you're doing the brain, you can imagine you have to do it sedated because they have to lay quietly. So if you do a sedated MRI in a 4-month-old, let's say, or a 6-month-old, it's dangerous, it's expensive. We certainly don't do it here. It has to be at a tertiary center, a pediatric center, where they can safely do that, maybe with an anesthesiologist for children, that sort of thing, just to get through the test, let alone the cost of it, as you can imagine. Well, it turns out this condition is a lethal disorder. So as of 2015, there is no treatment for Yoder dystonia. The treatment is comfort and palliative care and doing what's right for the child. And yet all this testing, all this suffering that one would go through appropriately, I mean, the doctors are just trying their best to understand. Now, if we know what's going on, if we can identify, Dr. Morton saw a child like this at a meeting we had actually in Norwalk in the fall of 2012. That was the first time I met him. We had a large meeting there with probably 250 people. Some of you might have been there. Many of the public health, the physicians, other providers, hospital folks, as well as probably 150 of the plain community, Amish and midwives and others. And though we asked people not to be bringing children in for evaluation, because this one doctor, this fellow visiting, he had maybe an hour or two, certainly couldn't be seeing all the disabled children in the Amish community. But one family did anyway, brought this child wrapped up. Dr. Morton, can you tell us what's wrong? He looked and checked and said, I bet that baby has Yoder dystonia. I thought, well, come on. It's not very likely. Well, we sent blood from the child, and a week later got a test back from him. The child has Yoder dystonia. So it goes to show you, if you know what you're talking about, you can begin to identify some of these syndromes. And in this case, again, as long as we know the gene, it's different if it's an unknown case, so you don't know what you're looking for. But in this family, now we know the condition. So I've delivered now 4 of her children. The 3rd child was delivered and also had developmental delay. This child was tested, also has Yoder dystonia. They also had a baby in December at the clinic. So they're, of course, hoping that their child is not affected. So we did cord blood testing, and that child is not affected. So it's, again, a 1 in 4 condition. But this is a lethal condition. They have 2 children out of their 4. And so this child, in distinction to what I had mentioned, this child is cared for at home. If there's an illness, she either comes in the clinic or I go out to the home to see the child. And basically, that doesn't mean the child wouldn't come into the hospital here, but what clearly isn't going to happen is the child isn't going to go into an intensive care unit, be put on a respirator, and go through all this stuff for a child who's dying. And so this first of the 2 children was getting worse and was doing poorly. And I saw the child a few times. We tried some things, and she continued to decline. And the last time I went out, I saw her on the kitchen table with father holding one hand, mother holding the other hand. She's like this, white as a sheet, looked like a little angel in her final days of life, cared for by her family in the context of her people and her community, and at very little or no cost, you know. And as Dr. Morton has said, the parents of these children with lethal syndromes are almost the most grateful, even compared to all the other kids with other even treatable disorders, because it's such a gift. I mean, it's not an easy thing having a child with this kind of a condition, but being able to know that the child can't be helped by current treatment and being able to care for them in the comfort of their home is really a gift for these families. So it's really changing the face of the care for the plain community in these kind of conditions. So our goal is to develop a collaborative medical home for these children with complex genetic disorders. We've got a strong relationship with the plain community. We've got a pediatrician through our hospital here, Dr. Hare, who's been spending a day a week in Lafarge. He's learning these conditions along with me. He's coming with me next month, or next week rather, when we go to Ohio, learning more about these conditions, getting acquainted with the various subspecialists and the geneticists who are expert in this care. And we've also worked a lot with the University of Wisconsin, so they've been kind of our primary partners through this venture. There's a place called the Weissman Center in Madison. It's affiliated with the University of Wisconsin Pediatric Children's Hospital there, and they specialize in genetic and metabolic disorders. Dr. Greg Rice and Scott Schwer are their two geneticists. So they're coming out to the clinic on a regular basis, and we're over there periodically and sending samples back and forth. And they're developing there the expertise to do what Dr. Morton has been doing in Pennsylvania, and Dr. Wang at the DDC clinic in Ohio for Dr. Morton for 25 years, Dr. Wang about 15 years, and the UW is learning these techniques and also developing the on-site gene testing. So much of this testing now we're sending to Madison to get it done. And they're figuring out a way to match the price, which is really a gift. Of course, if we can get it for $75 in Ohio, if they charge $200, we're probably not going to send it there. So they really realize that that's their competition. They want to gain the expertise and the knowledge base and learn to work with these conditions. And so we're kind of the portal through which the UW can gain that contact and communication with the plain community. We've also been working quite a bit with the Gunderson genetics group, Dr. Yadelay and Kevin Josephson there, the geneticist and genetic counselor there. So they're beginning to come out to some of the consult clinics, and we're developing these relationships and trading ideas and insights back and forth. So what's it going to look like? It's a little different than than a lot of the rest of the work that we do. Some of these conditions, like the Yoder dystonia, there's just a limited number of families of that SNP1 that I mentioned. I think there's been 5 families that, at the time they were diagnosed last year, 5 families that had been diagnosed with that condition. So there's really not many people that know anything about it. You can't really go to the medical literature and find information about it. You certainly can't go to a textbook. So we're developing disease summary sheets based on the information we've learned, the communication we've had with our collaborators, Dr. Morton and Dr. Wang, and the UW team, others that are studying it, other people who have had families with this condition. That all is going on the medical records, so that if they end up in our ER, for example, and they look onto our medical record, they'll see, well, what is this Yoder dystonia? And then they look on and they can see this is what the condition is. It's a lethal disorder. It leads to nephrotic syndrome, and they can kind of basically get information about it, as well as my own partners. Many of these things, and myself, as time goes on, you haven't looked at it for 6 months, you don't quite remember all the details. So that's helpful. A plan of care which specifically relates to the particular condition and that outlines interventions that may be helpful for the child or consultations that might be helpful, the genetic pedigree, who are the consultants who are involved with this child and how do you get a hold of them, lists of family members that have been screened, as well as lists of other affected families. This has really been a gift to some of these families. You can kind of imagine if you have a child with a condition like this that the doctors don't know much about, but you end up getting connections with, let's say, 10 families that have children with the same condition. They often develop these circle letters that go all through the country and through the communities of children with SNP1 or children with Yoder dystonia or things like that. They trade stories of things that worked for their child or treatments that seemed to help or ways that or just the trials and tribulations of what they've gone through. And sharing with others helps give them strength and give them a sense of peace about what they're experiencing, that maybe others are having the same issues. In addition, we've got a connection through the medical literature, so anytime an article does come up that references one of these rare conditions, then we automatically can get contact to that and include it in our list of references, so we're beginning to learn about these conditions, because it's definitely a work in progress as we work through. So that's kind of what the primary care would look like. At this time, we're integrating it into a full spectrum family medicine practice, which is what we have there in Lafarge. So we see all ages, we see all people, everyone is welcome. We have births going on down there. It's the full spectrum of work. So it's quite different than the groups out east. Dr. Morton sees only children with genetic disorders. So if like a sibling has pneumonia, they don't take care of those children. If the mother is pregnant, they don't know anything about pregnancy. That's not really their thing, and so they can communicate if somebody has a question or a concern. But in the practice we're developing there, it's going to be fully integrated into this kind of rural family medicine practice. The other issue that they have at the other clinics is they're pediatricians, so once they get to age 21 or so, they're girls with menstrual disorders or issues of pregnancy, all the various things there, it's kind of out of their league. So for us, of course, it's everyday stuff that we deal with all the time. So there'll be an easy transition from children with disorders to adults with these conditions. The tertiary care end of it has to be developed fully so that, and this is also a work in progress, so whether they're at UW or they're at Gunderson Lutheran, our dream is that they have something like an ombudsman, like a Walmart greeter, who, when this Amish family arrives, who have never been in a hospital, and many of them never been involved with healthcare of any way, and they arrive at UW Children's Hospital. Any of you that have been there, it's really quite the circuitous place. It's difficult to find out where you're going, but someone that could kind of greet them and welcome them and bring them to the right place, see that they have what they need, and help them with their housing and the different options that would be available. The other issue is that some of these children, if it's a neurologic issue, there might be 5 pediatric neurologists in the group. Well, it's not that helpful to talk to a different neurologist every time you call about a kid who's seizing. It's really very helpful to have one person who's primarily in charge, who's kind of leading the effort to help the child. And so we're working to try to develop these kinds of relationships. And I'll tell you, they're working at UW to try to develop it. It's not that easy for them. They're not sure either, but they're definitely interested in doing so and trying to work with this. We're hoping the day will come where our medical records are connected. Right now, nothing is connected really, so we're constantly trying to fax and make phone calls, and people show up and they don't know that we just had a note. We just saw them yesterday afternoon. We did all these tests, and then they show up there at 2 in the morning and nobody has access. So the day will come, it might be in the next year or two, or it may not, where our medical records will be interconnected. That's our goal. 40 minutes. I think that I'm going to finish up more quickly. I'm not going to go through each of the things. The first point here, this is just in December at the clinic. We had, out of our 10 births there, 4 of them related to families with genetic disorders. The first, perhaps, is worthy of a little additional comment. This is a young woman who actually has propionic acidemia, the condition that I mentioned that the child was at Mayo for that amount of time. She has been fortunate to go through her life unaffected. So these children often get seizures, strokes, end up with cerebral palsy, and they can develop a dilated cardiomyopathy, a large heart, go into heart failure and die suddenly. But this young lady has kind of gone through her life and has been unaffected by this. She's now married and pregnant when I met her in November. So she was about 7 months along or so when we met her. When we looked into the medical literature, there was almost nothing in the medical literature about how do you manage a pregnant patient who has propionic acidemia. It's exactly the stress of something like a serious illness, like a bad influenza, like we have this year with high fever, 104 fever, racking cough, such like that, or prolonged first-time mother labor, let's say an 18, 24-hour labor, where you're not getting much nutrition in and you're working hard, what we call a catabolic state. It's exactly the situation in which these patients can decompensate and have a stroke and such. So we were quite interested in trying to figure out what should be done. Couldn't find too much about it. So the team at UW, the Weissman Center, designed kind of a protocol for us they didn't really want to go to UW or to Gunderson or here for that matter. They wanted to come to Lafarge. So here we are in Lafarge, a little town of 700, in a clinic, no less, with this patient, with her first baby, and to go through a labor experience there. And we were doing our best to prepare and to offer her a safe birth experience. So their recommendations was to run a special IV fluid, which we contacted our pharmacy. We got on site, had it in the refrigerator, and then give a special medicine called carnitine intravenously every 4 hours through the labor. I'd never given this, so we had to look into it a bit. We had to order it. We did all that, so we were all ahead of the game. Unfortunately, she went into labor 3 weeks ahead of her due date, which usually the best laid plans. So when I went there at 2 in the morning to try to get things organized for her labor, we didn't have IV carnitine there. I thought, where is it? I know it was supposed to be here somewhere. We had ordered it. I called the pharmacist. Turned out it didn't actually come with the shipment that it was supposed to have. So she got out of bed, drove it to Lafarge. We had this treatment there, so the IV fluid was there, the IV carnitine was there. She got this treatment, and unlike some that have a very pleasant experience of a 4 or 6 hour first labor, which is always nice when it happens, she had a more typical 18-hour first labor. So she had a long catabolic stress. It was about 6 p.m. the next evening when she delivered, but she got the treatment outlined and everything went well. We monitored her blood work and urine for certain components, ketones and things, and she ended up delivering a healthy baby that evening. And since it hasn't been reported, we're putting together the data that we collected from this birth into a publication, and have worked with the UW team to publish it now through probably the Mayo Clinic Proceedings, which is a journal I read every month and have been for 30 years. And so we'll be able to contribute as well to the understanding of these conditions. And of course, we're just getting going. This is kind of the first of probably many efforts and publications in this regard. These are some of our collaborators. Of course, Vernon Memorial and UW are our primary collaborators. VMH has been really supportive of this work. This is not necessarily a money-making venture, as you could imagine as you look at the kind of thing we've been talking about, but it really makes a difference for families and for community. And of course, if we keep sick children out of the hospital, or for example, the child was at Mayo that had that bill for $750,000, they actually wrote off most of that bill at Mayo, which was very, very good of them. But if they didn't have to spend it at all and they could use it for some other child or family, wouldn't that be a better day? And that's, of course, what we're trying to achieve. But VMH has been really supportive in our efforts, our fledgling efforts really, to develop this kind of a program, and we're very thankful. We have a really close working relation with the UW Children's Hospital and the Department of Pediatrics, which is leading to all sorts of additional collaborations. So not this week, but next week, I'll be meeting with the head of pediatric cardiology at UW, designing studies of the natural history of hypertrophic cardiomyopathy in the plain community, which has never really been done. So nobody really follows the community over decades of time to learn what happens in these children who have the gene, but we don't know that much about how the disease occurs. So that's a collaboration currently ongoing. We're just beginning a collaboration with Gunderson. We're, I would say, the early stages of that. We have close relationships with the two probably best or largest clinics in the country doing this work. Two of the 3 or 4 only, and that's the Clinic for Special Children that I mentioned in Lancaster, Pennsylvania, which, by the way, is in a town about the size of Lafarge, with a genetic researcher and a gene sequencer and all this high-tech equipment. Is quite interesting. And with Das Deutsche Clinic in Northeast Ohio, excuse me. And then the Windows of Hope is a group that from Exeter, England, that we're working with, that I met at one of the other meetings just at breakfast. And this is a team from England who's done a lot of work with the plain community. They've been working in Northeast Ohio for 10 or 12 years. They're very facile in diagnosing these conditions, and they're actually going to be here next week for a clinic here in Lafarge with their 2 primary researchers. seeing families, some in the clinic, some out at the home, helping us sort out families that we haven't been able to do so far. So we're developing a close collaboration with them as well. The funding is a little challenging. Some of it is based on patient charges, but not a lot, about a quarter. About a quarter, this is just projections, we're just getting going, so we'll tell you in a couple of years how this looks. But community fundraising. Last October, the Amish did their first fundraiser for this project. It gives you a sense of their faith in the work that's going on. They all donated, you know, goods and services and such, and we raised $50,000 at that first auction. This is important to us, and I think it's also important to the people doing the fundraising. You know, they want to know that all of their people can have access. So far, we're able to work through the VMH Foundation, and there's a designated sub area within the foundation that allows funds to go in and be tax deductible through the hospital's 501c3. So that's been a big help to us. We've not had to go through that whole process of doing the development of a 501c3. We've developed a management board. We met now twice. We're meeting again in 3 weeks or 2 weeks with representation from the Plain community as well as from VMH and me at this time, and other representatives, including distribution throughout the state. And so that's a bit about that. This is a picture of what the new clinic, I could have said a while back, is going to look like, but actually if you drive by you'll see it's looking much like that now. We're scheduled to move in the last weekend in June, and we'll have an open house on the 4th of July, which is, I understand, a Saturday this year. There's an all-school reunion in our little town in Lafarge on that weekend, or that Saturday. So it'll be ideal for our community to have this amazing facility really in such a little town. So with a correct diagnosis and proper treatment, so much can be done for these children and families with so much less suffering and less cost. And a lot of it due to the pioneering work of Dr. Holmes Morton out on the East Coast, and the advent of improved genetic testing through the Human Genome Project. So that's that. So I'd be happy to take questions as long as you have time.
Another pregnant lady that had PA, how did you know she had PA? Was she from a family that had PA?
Yeah, I think what happened is, sometimes what happens is these kids come in crisis, and the diagnosis is made, so let's say at UW, and then once they make the diagnosis, they realize 1 in 4 of the siblings could have the condition, and so they test all the siblings, because if they've been so far unaffected, what they found out with propionic acidemia is that these children are normal and develop normally until they get an acute illness. That's why I say the kind of catabolic stress of, say, influenza or acute gastroenteritis, pneumonia, and they become very ill, and they have high fever, and they're not eating, and they're burning up more calories than they're taking in, and this leads to a toxic development of these byproducts that occur as a consequence of that condition, which then cause these brain strokes and brain injuries. So they have this decremental drop. So they have a stroke, and then they're not doing well, and they go through an illness, and they have another stroke, and then they're paraplegic, and then they have another stroke, and they're uncommunicative and this sort of thing. And so the goal is to intervene with illnesses with children like this to prevent this. And of course, Dr. Morton, one of the unique things about his practice is not only is he a geneticist and a genetic researcher, but he's a pediatrician first. And he and another gentleman went into this practice, so they're not only doing all the gene testing and the research and studying these children, but when they're sick, they're taking care of them, which normally the geneticists, they see them twice a year, in the clinic. When they get sick, they go into the hospital. But what he was doing, and PA is a good example, is he would see these children, and he'd see what happens to them, and they get a stroke during this sickness. He's like, there must be a way to prevent this. So while they would be ill, he's doing like these urine amino acid scans, which normally, if you do them here, we have to send them to the West Coast to get them done. They cost $400 and we get a result in about 3 weeks. Well, that's not really very helpful when you're taking care of. So he would do them every day on these children. He can do them right in his lab in the little town, like I say, in Lafarge. And so every day the children were sick, he would be running these amino acid tests on their urine. And of course, the same thing is happening to them as has happened to them in the past. They're developing strokes, and he's desperately looking for new ways to intervene, special IV formulas that go around the enzymatic defect that occurs in propionic acidemia to help obviate this buildup of these toxic byproducts that occur. And what he found, not easily, but over years of this work of caring for these children, that if you do it right and you get the right mixture of amino acids and the special IV fluids, which he has to have made himself at their local pharmacy, that you can prevent this buildup of toxic metabolites and prevent these decrements of loss of function. And and basically what you see now are children who are 17 and 20 who are running and playing, and mostly healthy children who previously had the consequences of this undetected illness. So they start out with a child who comes in crisis, let's say a stroke or heart failure. They identify others in the family, and then what Dr. Morton found, to his surprise, when he tested some of the parents, occasionally he'd find a parent who actually had propionic acidemia. So they went through their whole life and managed to avoid the hits of these catabolic stresses, these significant illnesses, and so they were still functional people, visiting, getting married, didn't know they had any condition, and then had babies with it. So that's the way this woman was found. And then of course she was treated, never had an illness, and as you might expect with a teenager, who's told to eat a certain sort of way, even in the Amish community. As time goes on, they're increasingly flexible in the way that they approach it. And she basically went into the pregnancy feeling quite invincible. She has this, but she's fine. And so her perception actually of her labor experience, I think, is that it was over-medicalized. We did too much. So yes, we did it. She had a good baby. Everything was fine. But I don't think they were that impressed with us. They were kind of, And it could be she's right, I don't know. We don't really know the answer to these questions, but we're certainly trying to figure it out. But so she was one of these who kind of dodged the bullets and of that particular condition. You see the same thing in MSUD. There are all these. It's so interesting to me. I've gone my entire career ignoring the Krebs cycle, which for those of you in science, we had to learn it. For most of the rest of you too, you had to learn it sometime, whether it was in high school chemistry or in your college somewhere. And I always reassured my daughter, who's a nurse, don't worry about it. All you have to do is get through the exam. You'll never look at it again. Well, 30 years later, here I am at these meetings, and they've got this Krebs cycle, and this isovaleric acid comes here, and this and all the other issues, and it's exactly what they need to be worried about, and they know exactly what's going on with these conditions, which are enzyme defects, and it builds up just as you'd expect, proximal to that, and then these are the things that cause the toxic metabolites, and how can we mess with these amino acids in order to obviate that issue, and that's kind of the work that they've done too. It's very interesting. But I still couldn't draw out the Krebs cycle for you. Maybe in a year or two, but not now. Yes?
When you down the line, when you have this wealth of knowledge that's been documented, and they can compare some of the conditions that are common with the plain community and the English community, will they possibly be able to come up with, connections that will find cures for some of this?
Yes. The interesting thing with this is, my perception going into this whole project was that most of these things were untreatable. Maybe you could diagnose it, but there's not too much you could do. And obviously with the description of a child with a lethal disorder, you say, well, that's still a gift, if you know what it is. On the other hand, what I learned from Dr. Morton when he did his presentation back in 2012 was if you compare these genetic disorders with the conditions we normally see in everyday family medicine, so diabetes, ischemic heart disease, bypass surgery, whatever have you, the cures with genetic syndromes versus conditions which you can benefit but you cannot cure, like diabetes would be a good example. You can ameliorate the consequences of diabetes. If you do a good job with your treatment and the patient's working hard at it, they can do pretty well, but you still can't make them a non-diabetic person. And then there are some conditions like certain kinds of cancer, pancreatic cancer, other things that are pretty darn difficult that we still haven't made as much progress as we would like. When you actually look at the genetic conditions and the frequency of cures and of conditions that are ameliorated by good care, and those which are essentially untreatable or lethal, it's actually rather similar to that stuff that we treat every day in terms of the... But that's a little side question to what your question was. And really there are many corollaries from this work into the English, into the non-plain community. First of all, with the actual treatments of these disorders. So if you have a very homogeneous condition like the MYBPC3 gene mutation causing hypertrophic cardiomyopathy, and you learn about what's the consequences of pregnancy in a patient who's genotype positive but healthy, those things may or may not, but they may well transition over into the English community. The other thing to realize is that all of these conditions in the plain community are also all in the English community. It's just that this group of Amish, what we call founding group of Amish, came from Europe in the 1700s, maybe 100 families, but they came intermixed from the other families, and it's only because of a set of religious and cultural perspectives that they ended up getting focused in a certain way. So there are conditions like this MYBPC3 mutation of the hypertrophic cardiomyopathy. The same gene is in the English. Propionic acidemia, same gene is in the English, although the English have a wider genetic spectrum, so we have other conditions too. So there's a wide variety of lessons that come from this work that translate directly. The other thing we're learning as we're developing the kind of collaborative medical home concept there is a lot of the systems issues we're looking at for improving care for these kids with complex illnesses actually translate rather well to my patients with elderly patients with just complex multiple conditions in terms of the relationships with specialists, how many different people are seeing them, how well the information is getting communicated back and forth. And so there are a lot of parallels to the work, and I can see the work we're doing in this particular small part of our practice benefiting our entire practice in doing even better job with relationships and that sort of thing. So just on every level, it seems like there are parallels and benefits to the practice that we're seeing from learning.